Hello, what's up everyone? So finally NEET PG 2023 is done. I know you must be feeling okay, finally relieved, and you deserve it, okay? All the tassel, all the hard work you have put in will finally pay off now. Just await the results. You deserve this moment, you deserve to live it, love it, and enjoy it. But before you go on to that, let's discuss some ophthalmology questions which we got by recall. So before we proceed, please be assured that every question has been put to the best of my knowledge and capacity according to the recalls given by you all. Ophthalmology this year was quite easy, not very challenging, very straightforward. If you had your concepts and facts cleared, trust me, all 10 of them would have gone right. Now let's tackle the image based question first. Our sequence will be from easy to hard kind of, and what will be unique about this recall is we will also cover the other potential MCQs which might form around the options which were given, and also some theory part around the options as well. So let's begin. So the easiest of all was this. You were given this diagram and you were asked the type of refractive error. It's so straightforward, right? Now this is a Sturms conoid and there's no debate about the fact that it represents the refractive error known as astigmatism. So astigmatism is nothing but when you have a toric surface and there is focus at two different points, okay, due to the toricity of the cornea in this regards. So the correct answer in this case was astigmatism. Okay, I hope this was right for you all. Now the second one was very tricky because some of them were confused about which image was given. So after going through a lot of recalls, this was probably the image which was shown in the exam. So first of all, it was a child. Secondly, there was a nodular swelling or swelling, whatever was there mentioned in the paper, in the left eye. So child with a nodular swelling with this diagram, with a swelling at the limbus, directly points towards limbal dermoid. Okay, there is no debate about it. But now where the confusion went was between dermoid and dermolipoma. Pingicula and pterygium are out of question. How? We'll just see it ahead. But first we need to differentiate why is it not dermolipoma and why is it dermoid. So for that we need to clear our basics first. So let's get on to a bit of theory around this. So when we see a dermoid versus when we see a dermolipoma. So first of all, remember that both are choristomas. So what are choristomas? Choristomas are normal tissue at abnormal sites. That's it. Now both are choristomas. So how do you differentiate it? It's very simple. Just concentrate over here. Number one point, dermoid is a mass of collagen tissue containing dermal elements, okay, and covered with stratified squamous epithelium, SSE. This is dermoid. When we talk of dermolipoma, it is nothing but dermoid in itself plus adipose tissue in it. Okay, so that's why it is called as dermolipoma. Another name for dermolipoma is lipodermoid. It's just a twister, nothing more. So dermolipoma and lipodermoid can be used interchangeably. More important to remember is that it presents in childhood, while it presents in late childhood, you can say, or in adults. So the first point is clear over here because what we got in the question was a child. So this is pointing more towards dermoid. Number 3 is the location. Location, if you see, it is most common at inferotemporal quadrant of the eye near or at the limbus. While this dermolipoma, it is more common at the outer canthus. Also, when I'll show you the image, it will be very clear that dermolipoma is very classically different as compared to dermoid. Henceforth, when you think of dermoid in the eye, make a habit to call it as limbal dermoid. It makes a lot of things easier because as you can see here, there is a mass at the limbus. So your brain will automatically go to that option. Okay, I have to look for limbal dermoid, and that's where the option lies over here as well. That is dermoid. Now, obviously, pinguicula and pterygium are not the option. We'll just have a look at what potential images could be for other three options which we have seen over here. Okay, so this is what I was talking about. This is the dermolipoma. It arises from the outer canthus. Okay, now this can increase in size, and this is mostly seen by adults when they are doing some makeup, lifting their eyelids or something like this. So it's a coincidental finding, it's an incidental finding. So dermolipoma, it's again very benign. The DDs you should remember over here, which is again a potential MCQ, is orbital fat prolapse, lacrimal gland lobe prolapse, and very important again is lymphomas can also present with a mass like this. Am I clear about this? So these are again the potential MCQ areas which you can remember with this diagram or the figure. This is the limbal dermoid. 100% limbal dermoid is the right answer over here. Now this is the pinguicula. Pinguicula and pterygium are obviously not the answers. It is so distinctly different from what was shown in the exam. Basically, pinguicula and pterygium, if I have to tell you and write you and give you, pinguicula is nothing but pterygium ka beta. So basically, pinguicula is the precursor of pterygium, and both are nothing but elastotic subconjunctival degeneration. The only difference is that pinguicula has not invaded the cornea. Okay, pterygium invades the cornea. If I have to be specific again, that which layer of cornea, potential MCQ, which layer of cornea it invades, that is Bowman's layer. That's it. So these two were were out of question. Okay, so the confusion here was between dermolipoma and dermoid. Always the right answer here is 100% dermoid, or in other words limbal dermoid. Let's move on to question number 3. So this was the image given. They had given us gradual diminution of vision, presenting with myopia, identify the refractory condition. When you get this, also look at the options. Okay, when I look at the options, all are types of myopia. So I reframe the question in my mind in a way that what are they asking me? They are asking me the type of myopia. Makes my thinking a bit different and simple to figure out which is the right answer over here. Now, if you can figure out, you should concentrate on this. This is a slit lamp image of a cataract. What happens in cataract? In old age people, what they get is second sight, because what happens is, due to increased density of the nucleus, the refractive index of the nucleus in the eye changes. Nucleus, that is the lens in the eye changes. So the eye becomes more myopic, and there is a myopic shift. Due to the myopic shift, their presbyopic glasses, they don't need it anymore, and they feel their vision has improved. But in other words, the cataract is progressing. Okay, so that's why this is called a second sight, where there is myopic shift, which is caused due to index myopia. That is the right answer over here. Now, why are others not the right answer? Axial myopia again will have gradual diminution of vision, but it will be seen in growing people, in growing adults or children. They will not give you this diagram if they have to ask you about axial myopia. There will be gradual DOV, but not associated with cataract at any point of time. Positional myopia is again out of question. Curvatural myopia, the question does not go in line with any of the features of curvatural myopia, where the curvature of cornea or the lens like lenticonus or keratoconus is being mentioned. So the right answer over here has to be index myopia, and I hope a lot of you have gotten it right. Okay, now moving on to the next question is the visual pathway lesion. Now there are a lot of theories by a lot of students attempting NEET that what was the question. So what I thought is I'll go through all the lesions, important lesions of the visual pathway. So the question was something like this: 65-year-old with a visual field defect or visual field loss. Now the confusion was it a bitemporal, was it a left-sided loss or the right-sided loss? If it is a left or right-sided loss, we call this as call it as right or left, respectively, homonymous hemianopia. There was a space occupying lesion and he was on treatment, the details of which are not known. If any one of you remember, please put it in the comment box, we'll discuss it ahead. And what was asked was the most probable location of the lesion. So what we'll do is we'll just go through all the visual pathway defects. Okay, let's have a look at this. This is the normal visual pathway. We all know that light rays coming, suppose this is the right eye and this is the left eye. You're seeing this from above. Okay, so light rays coming from the nasal side of the right eye will fall on the temporal retina, and light rays coming from the temporal side of the right eye will fall on the nasal retina. That's how the representation is in the system, in the retina. So the nasal fibers will decussate to the opposite side, while the temporal fibers will pass uncrossed on the same side. So if you know the nomenclature, which I am very sure of, this is the retina, this is the optic nerve, this is the optic chiasma, this is the optic tract, and these are the optic radiations. Fine. So what if the lesion is at the level of optic nerve? Everything is cut off. Entire image, entire capacity of the eye to look at anything from that eye is cut off. So what you get is a monocular vision loss. Very logical. Second, now this is where it might have been asked, the lesion at the optic chiasma. Very important. At the optic chiasma there is crossing of fibers. Okay, so the central fibers are involved. So what will happen is left-sided, remember, left-sided nasal fibers and right-sided nasal fibers which are crossing are cut off. Now, if they are cut off, what are they representing? They are representing the temporal field of view. So, we get a bitemporal hemianopia, or we can also call it as heteronymous bitemporal. Why heteronymous? Because they are not on the same side. Hemianopia. Okay. Now, anything beyond the optic chiasma, take any one side. Okay. Suppose we take the right side over here. So, anything beyond the optic chiasma up to the lateral geniculate body, if there is a lesion, what will happen is the opposite eye will be affected. Okay. Also, the same side eye will be affected, but in a different manner, and that we call it as homonymous hemianopia. Suppose the right side is affected. So what is happening over here is the right side temporal fibers and the left side nasal fibers are cut off. So the left side temporal field of view and the right side nasal field of view is gone. So this is again hemianopia, but this is on one side. So we call it as homonymous hemianopia. So the whatever the options were, I hope you have marked it correctly according to this. Now these three were not into consideration because it was not asked when I look at the question which was framed in the exam. But just to revise, we can just go through it. Okay. So this theory part is clear. Okay, fine. So yeah, beyond the lateral geniculate body, what is happening is optic radiations. So these go through the temporal lobe, part of them go through the parietal lobe. So if the temporal lobe optic radiations are affected, what we get is superior homonymous quadrantenopia. Again, remember, any lesion beyond the optic chiasma will be showcased on the opposite side. So if the right sided temporal optic radiations are gone, what we get is a left sided superior homonymous quadrantenopia. If the parietal lobe optic radiations are affected, we get a inferior left sided homonymous quadrantenopia. Okay. Very interesting is the last lesion at the level of cerebral cortex due to the vascular involvement of posterior cerebral artery. So what happens here is the macula is spared. Why is the macula spared? Again a potential MCQ, because macula has a representation on both the side of the visual cortex. So it has a bilateral representation, bicerebral cortical representation. That's why macula is spared. Remember this point. This can be again a potential MCQ because topics are generally repeated. The questions are not. I hope visual field is clear now. Okay, so the next question was an image based question again, where something like this was shown. only one of these two images, that is this was shown. Very classical. If you can pick up the salient features: infant, cloudy cornea, difficulty in opening eyes, watering from eyes since birth. It is so easy, so classical. Let's put it in scientific terms. Watering from eyes is lacrimation. Difficulty in opening eyes, we can label it as blepharospasm, or there can be photophobia, which is leading to difficulty in opening eyes. More important than that is cloudy cornea in infant. All of this is pointing me only to one answer, that is congenital glaucoma. This is undoubtedly the right answer. No other option makes sense over here. So what you should remember in congenital glaucoma is the triad, that is, I'm writing over here BPL. B stands for blepharospasm, P stands for photophobia, and L stands for lacrimation. Okay. Now, the most common symptom of them is this L. L is the most common, that is lacrimation, while P, that is photophobia, is the earliest symptom of congenital glaucoma. Now, you must have read well about congenital glaucoma, but just to brush up the salient features and the important points, congenital glaucoma, primary congenital glaucoma to be precise, has three types, that is true, infantile and juvenile. The most common is infantile glaucoma, infantile primary congenital glaucoma, which presents at the age of 3, and juvenile from 3 to 16 years of age, which is the least common. Okay. That's it about it. Now, why not the other options? We have to look at why not the other option. Let's consider one by one: mucopolysaccharidosis, congenital cataract, and ophthalmia neonatorum. So when we see at congenital cataract, if you look at the image, okay, one more confusion was there, that yes, you are right that congenital glaucoma is generally bilateral. But you should remember that congenital glaucoma, though bilateral, is often asymmetrical. So, okay, any presentation in human body about any disease cannot be bookish. Number one point. Always you should remember this. No presentation of any disease in any subject in any human body is completely bookish. So often congenital glaucoma presents bilaterally, but again it's asymmetrical. So here the left eye is affected more than the right eye. So don't get confused that why दूसरा आँख affected नहीं है, so I should not go with that answer. No bookish knowledge is applicable in the real world when it comes to diagnosis, because book के जैसा कुछ भी नहीं दिखता है, थोड़ा सा वेरिएशन हमेशा रहता है हर केस में. Okay, am I clear over here? Well, let's move on to the other three options. Let's figure out. So this is the congenital cataract. What is the difference again? It can be unilateral, it can be bilateral depending on the cause, but again it's such a well defined lesion. If you can see, it's so well defined. It's within, the plane is deeper, it's behind the iris. You should be able to appreciate it. It's very well defined. Okay, and it will not be bluish. Corneal clouding gives some amount of bluish tinge in congenital glaucoma. Also, congenital glaucoma gives you a blue sclera because of raised IOP. There is stretching of the sclera. The eye is very distensible in infants, and you get this blue sclera in congenital glaucoma. But this, in congenital cataract, it's such a well defined opacity and at a deeper plane. So this is a catch point. This is again mucopolysaccharidosis. Why again mucopolysaccharidosis cannot be the answer? Very important is the age of presentation. It presents at an older age. It does not present at infant. It will present at early to late teens only. And most important, it has other systemic features as well. Okay, so this is the catch point. Presents at older age, that is in the teens, and other systemic features. And also the eyeball is normal in size. It is not ophthalmic as in congenital glaucoma. Okay, so these are the differentiating points. Now this is very classical: ophthalmia neonatorum. Any infection, any severe inflammatory disease of the conjunctiva in the first 30 days of life has to be labeled as ophthalmia neonatorum unless proved otherwise. And you treat it with antibiotics. If they ask you which is the safest antibiotics in a neonate, remember it is tobramycin. Okay, tobramycin is the safest local antibiotic which can be used as drop or ointment in the first 30 days of life. Avoid using fluoroquinolones like ciprofloxacin or moxifloxacin ointments. It's not advisable. You have to go for tobramycin. Okay. The next image based question was very easy, where I think personally that this DM was something to bug you. It was to confuse you, because if you concentrate on again the catch points, see, 65-year-old, okay, old age. Number one, colored halos. Now, colored halos can be due to conjunctivitis, can be due to cataract. Okay, these are the very common causes, or can be due to acute attack of glaucoma. So, these three diagnosis should come in your mind when you think of colored halos. Now, there is gradual diminution of vision. Conjunctivitis, there is no diminution of vision. There is irritation which might lead to diminution, but then it's a sudden thing, like develops over 1 or 2 days maximum. Acute attack of glaucoma, again it's a sudden attack, so it is not a gradual diminution of vision. So I have now left with only one option, that is cataract. I have not even gone to diabetes mellitus. Okay, that's what I am telling you. DM was here to confuse you. Now now they have also shown you an image which is so conducive with what you were thinking. So before you jump onto options, make a habit of developing your own mode of thinking. Okay, this helps you a lot. If you are very well thorough with your knowledge, you will develop it automatically. So what I see over here is this iris shadow. It was near mature, or obviously it's not mature, it's immature cataract. It's not sunflower or snowflake cataract. Even if it is sunflower, snowflake or rosette cataract, BSL control is not the management. Any cataract, always remember, in modern times, phacoemulsification is the standard surgery with IOL implantation. Any cataract, mind my words, any cataract has this as the treatment of choice, provided there is no abnormality in the structure or in the case you are seeing per se. That is, for example, there is gross subluxation, where obviously phacoemulsification will not be possible because of difficulty in maintaining the anterior chamber and instability of the lens in itself. Because if you attempt phacoemulsification in such cases, what will happen? You know, the lens will drop down in the vitreous and it will be another complication. So in such cases, we opt for small incision cataract surgery. Okay. So mark my words again, phacoemulsification with IOL implantation is the standard surgery and treatment of choice in all kinds of cataract. Again, we will exclude zonular cataract because zonular cataract does not cause colored halos. Fine. Okay, so we are left with only one option. It's immature senile cataract. Phaco with IOL implantation was given as the option. Goes very well with what we were thinking. That is the correct option of choice which had to be marked. Okay, let's move on. Last 4 questions. Okay, this is one of my favorites. Fine. Something like this was given, stained, something green stained over the cornea in the form of dendrites, and then you were asked best diagnostic modality for this corneal condition, or identify what is being shown in the figure, that is the slit lamp examination figure. Number one, you should remember, whenever you see this bluish image with greenish lesions, it has to be fluorescein dye with cobalt blue filter. It's very basic. Okay, so when do we use it? We will see rose bengal, lissamine green does not very well go, because lissamine green is, first of all, it appears green. Very important, not this green, a different green. Okay, lissamine green appears something like this, and it is used to stain the conjunctival part, not the corneal part. Okay, for your MCQ purpose, remember, मोस्टली कंजंक्टिवा स्टेन्ड दिखाएंगे तुमको फॉर लिसमिन ग्रीन. और ऐसा होली का जो कलर होता है ना, बाय द वे हैप्पी होली, इट्स कमिंग सून. सो होली का जो कलर होता है ग्रीन, बस वैसे ही दिखता है. सो लिसमिन ग्रीन विल अपीयर ग्रीन एंड देयर इज नो फिल्टर विच इज टू बी यूज्ड. रोज बंगाल डाई appears something like this. Okay, the first image, rose bengal dye will appear something like this, and it is used to stain the dead debris or the mucus in very severe dry eye diseases. Okay, this is again nothing to be really talked or taught of, because it's very straightforward. It's fluorescein dye 100% with cobalt blue filter. We'll just see at a few of the theory part of the fluorescein dye, because it is the most important dye in the ophthalmology. So when we talk of fluorescein dye, remember what we get in the market as concentration is 1 to 2% drops, or we get ready-made strips of 0.6 to 1.0 milligram strips we get. Okay. For fluorescein fundus angiography, the concentration can be 10% or 20%. So remember the concentrations. Now, what are the properties? It's an orange colored dye. It absorbs blue spectrum and it emits yellow green spectrum. Blue spectrum is around 490 nanometer and this is around 530 nanometer. Okay. Now the property is that it adheres to the basement membrane, and that's why wherever there is denudation of the epithelium on the cornea, basement membrane is exposed and that's where it adheres, and we get a picture something like this. It's very important to pick up dendritic ulcers because they're very small, very thin, and slit lamp पे normal illumination पे थोड़ा difficult हो जाता है. Obviously experienced ophthalmologists can pick it up without dye as well, but it's advisable to confirm that you use a dye. Adheres to basement membrane and therefore stains epithelial breakdown areas, and these areas are very common in DED. DED matlab dry eye disease, corneal ulcers. Okay. So what are the other uses? Very important other uses. ये दो तो हमें पता चल गया कि dry eye disease में use होगा, corneal ulcers में use होगा. Dry eye disease में ये severe cases में stain ले लेगा. You can also calculate what is known as TBUT, that is mark my words, tear break up time, that is TBUT, or you can measure TMH, that is tear meniscus height. टीयर मेनिस्कस हाइट मेजर कर सकते हो, टीबीयूटी मेजर कर सकते हो और उस हिसाब से ग्रेड कर सकते हो कि ड्राई आई की सीवियरिटी कितनी है, बट नॉट इन द syllabus for you for the NEET. Just remember that this is how dry eye is evaluated using fluorescein. What are the other uses of fluorescein? Okay, so applanation tonometry, which is the gold standard for the IOP measurement, which is also known as Goldman's applanation tonometry or GAT. Then Siedel's test. I'll cover this in detail when we have lectures on this. Then there is Jones dye disappearance test. Okay. Then there is very important fluorescein fundus angiography and contact lens fitting. Okay, remember all this. I hope this is clear. Okay, if you want to take a screenshot, please do over here. That's it. We'll just have a look, quick look on the other dyes in ophthalmology, so that you have an idea कि ये dyes है और you don't miss them. Okay, so fluorescein we have seen. Lissamine green staining is mainly for the conjunctiva. Alcian blue is not used nowadays because it's very irritating. It's an irritant. Rose Bengal staining is this one. It is for the debris and mucus. Trypan blue, very interesting. Trypan blue is this. It is used to stain the anterior capsule of the cataract so that we can make a continuous curvilinear capsular axis easily. And then there is something known as brilliant blue or indocyanin blue. Brilliant blue. It's brilliant blue. It is used to stain the ILM, internal limiting membrane in the retina. ILM. Why is it stained? Because we do something known as ILM peeling in cases of macular hole. This is a very high yield point. If you want to remember, please remember. If you want to forget, feel free to forget. But brilliant blue is used to stain the ILM. Indocyanin green is again can be used in the posterior segment staining. Or it can also be used for angiography to see the choroidal circulation. So we call it ICGA, indocyanin green angiography. These last two are rare, not approved by FDA as well. Sorry, these three are not approved by FDA as well. So forget about this. Just remember the name: Brilliant Blue, Acid Blue, Bromophenol Blue, Patent Blue. All these three are not approved by FDA. So next, eighth question was, there was a child. Again, that is the catch point. Always age बहुत बड़ा catch point होता है. Age, gender, so always pick it up. There was a child, dark colored expanding lesion on one side of face since birth, something like this, according to my knowledge, what I have recalled from the students, कि ऐसा दिया था. And most likely long term complication क्या हो सकता है? What can be? This is on the face, outside the eye, over the eyelid. Forget about going to cataract, loss of vision. No, this is ruled out. Sometimes you have to rule out the questions. Okay, सब questions के answers पता होना जरूरी नहीं होता है. You have to rule a few of them out so that your life becomes easy and you are quicker at attempting the questions. And trust me, it's a very efficient way to do it. I have done it personally and it worked for me. So the options left for us are glaucoma and melanocytic melanoma. Now melanocytic melanoma is nothing but malignant. By the way, what is this? This is melanocytic nevus. Okay, this is something like this. This is again known as nevus of Ota, but I have inquired, this was not the image which was given in the exam. So we're not discussing that. This was 90%, this was the image. If there's any change, please write in the comment section or mail me on vedant.murkey@gmail.com. So this is a melanocytic nevus. The malignant transformation is very rare. So we rule out this option. Glaucoma is the most apt answer for it. The pathophysiology is the melanocytes will proliferate as they are doing over here, and over the face also some of them will approach through the cornea, through the trabecular meshwork into the anterior chamber, block it and cause raised IOP and thereby glaucoma. So the correct answer here is glaucoma. Okay. Now last but one, again pick up 2-year-old, mental retardation, cherry red spot. Such a good question. The good part or the best part over here is you had to remember that there was no mention of organomegaly. So all of these metabolic storage disorder can have or do have organomegaly, with Gaucher's and Niemann-Pick also having cherry red spot. But Tay Sachs is the only option where there is no organomegaly. So even if I am not given the above question, the question can be framed as find the odd one out. There is organomegaly in 3 of them. Tay Sachs does not have organomegaly. So even if you do not have this, the odd one out here. So your mode of thinking is changing. Now think here that what I am thinking here is I have to pick one odd one out. So it does not matter what is the question for me here. What matters for your exam is you get the answer right. Does not matter how you are approaching. You can customize it according to your own comfort and your own acumen and how you approach studies. Okay. So Tay Sachs disease, it's a very straightforward answer. Many mnemonics are available, but for what I devised for my own self for remembering the causes of cherry red spot is MTV drug. MTV is a channel and drug. Okay, so M stands for metabolic. Okay, M stands for metabolic, where I have again made another MCQ, mnemonic, that is the sexy new great FM. We'll see what it is. Okay, now T stands for trauma, V stands for vascular. The most important cause which you should not forget is CRAO. Okay, it's a topic in itself. The last thing are the drugs. Okay, so I hope now this is your dhacha, this is your blueprint of how to remember the causes of cherry red spot according to me. If you have some other mnemonic, please mention it. If you feel free to use it if you can remember that. I am more comfortable with this. Now the metabolic causes are very important. Number one is the sexy new great FM. T stands for Tay Sachs disease. Tay Sachs disease, which is also called as GM2 gangliosidosis type 1, and the gene in, see, I am covering MCQs here as well. The gene involved is hex A. Okay, the what was the next? Sexy. S stands for Sandoff's disease. It is again GM2 gangliosidosis, but it is type 2, and the gene involved is hex B. Nu stands for Niemann-Pick. Okay. G stands for GM1. GM2 हो गया ना, अभी GM1 gangliosidosis याद रखो यहाँ पे. उसका दूसरा नाम होता है लैंडिंग डिसीज, और जी से एक और डिसीज आती है, वो है गाउचर. गाउचर बहुत मतलब आखिरी ऑप्शन कंसिडर करना चाहिए जहाँ मेरे हिसाब से. हमेशा गाउचर पे जंप ना करे. Look for other options which are more relevant. So the sexy new great FM. F stands for Fibers disease and M stands for metachromatic leukodystrophy, and second is multiple sulfatase deficiency. ओके, सो ये हो गए आपके मेटाबॉलिक. एम वाले हो गए सारे. ठीक है, मेटाबॉलिक. टी स्टैंड्स फॉर ट्रॉमा. ट्रॉमा तो बहुत आसान है, इसका दूसरा नाम आपने याद रखना है, दैट इज बर्लिन्स इडीमा और कोमोशियो रेटिनी. Basic you should remember why is cherry red spot happening, because the entire macula entire retina goes white and the macula is red, so it appears as a cherry red spot. In drugs you remember something known as महाराष्ट्र में जो हर सिटी में होती है, that is MIDC. so M stands for methanol poisoning, D stands for dapsone का overdose, and C stands for carbon monoxide. Okay, remember. So these are the causes of cherry red spot. I hope I am clear about this. Just take a screenshot if you want to from here. Okay, yeah, that's it. So last question. Yes, this was very interesting, very easy also. So we began with easy, we are ending with easy. So there was a patient with dementia, golden ring. Now the confusion was, कोई बोल रहा था सर iris पे है, कोई बोल रहा था सर cornea पे है. So basically what I then researched is, and I found in literature, is the golden ring appears to be on the iris. It appears to be on the iris, but basically it is a deposition of copper at the level of Descemet's membrane in Wilson's disease with neurological involvement. What is important over here is neurological involvement, because most of the cases of Wilson's जहाँ पे neurological involvement है उन्हीं में KF ring दिखती है. This is not a rule, but this is a majority. That's why you should remember it. And very classical, very easy is what you will do. You will do serum ceruloplasmin levels. Okay, because it binds to copper. Copper बढ़ जाएगा, ज़्यादा bind कर जाएगा, fall हो जाएंगे. So which investigation will help? Serum ceruloplasmin. And this is how a classical KF ring looks. It's not very classical always. इतना frankly नहीं दिखता है, but exam में इतना frankly ही दिखेगा mostly. आपको micro बहुत small deposits diagnose करने की ज़रूरत नहीं है. So this is how a KF ring looks. So as I told you, it is a deposition in the cornea, but it appears to be over the iris. This is what literature also says, and this is what your question also said. Iris, cornea फर्क नहीं पड़ता है. We have to catch the salient features, that is dementia, golden ring. Talking about eye, that is over cornea, iris. It has to be Wilson's or other cholestatic disorders. So you have to do ceruloplasmin levels. Okay. Other are, that's why out of question, because this was a very straightforward answer. Okay, that's it. I hope maximum आपने सही किए होंगे. Ophthalmology काफी decent था इस बार. And that's it from my side. I hope you liked the video. Please leave your comments. If any suggestions, improvements, critics, everything is most welcome. You can mail me your queries, any other topic you would like me to cover soon. I will try my best to make one video on it and upload it. This is my email ID, एंड सी यू अराउंड. एंजॉय. जो सोचा था करना है प्लीज करो. एग्जाम के टाइम पढ़ाई करते समय बहुत सोचते हैं कि हमने ये करना है वो करना है. करने का समय आ गया है, अब रिलैक्स मत करो, कर लो यार, मतलब मजे करो. ठीक है, बाय. इट्स बीन अ प्लेजर.